and start our recording. And then I'm going to let everybody in and turn off the waiting room. Welcome, everyone. So glad you could join us this evening. I'm going to get us started with just a quick video about the American Association for Cancer Education, which is one of your sponsors of this engagement lounge today. And then I'm going to go through some housekeeping notes and hand it over to our program for the evening. All right, starting the screen share. Here we go.
I joined AACE in 2008 when I was a postdoctoral fellow at Moffitt Cancer Center at the urging of my mentor at the time, Dr. Kathy Mead, since the annual meeting was to be held in Clearwater Beach, Florida. We organized a panel at that conference on barbers as prostate cancer health educators. We published findings from this prostate cancer education study in the Journal of Cancer Education, or JCE. And since then, I've continued to publish my research in JCE. And a few years ago, I was invited to join the editorial board. In 2016, with my colleague, Dr. Levi Ross, we co-edited a special issue of JCE on cancer prevention and control in African Americans. I first served on the ICEC Conference Planning Committee in 2014 and joined the Executive Council first as a member at large in 2018, and I'm now currently serving as Secretary of the organization. It has been a great experience getting to know fellow AACE members through the annual conference and by serving on the council. It has helped my career by serving as a regular reviewer of the journal and participating in the annual conference to hone my skills as a cancer education researcher.
Okay, and I will also just say that video from Dr. Luque is just a little bit old. He's actually the vice president of the organization now. We recorded it last year, so he has moved up in his role in the organization. Welcome to this engagement lounge on colorectal cancer prevention, screening, and care, which is organized between AACE and the Regional Cancer Disparities Collaborative. We're very glad to have you here. Quick rules of engagement. Just noting that we are recording and we are also live streaming to both the AACE Facebook page and the AACE YouTube channel. So that might be useful for you to know, especially if you want to go back and find a recording of this in the future, because it will be there in our videos. Please rename yourself if you have any, sometimes the name on your Zoom might be like your child's name, or it might be the name of the device you're on or something. So if you want to speak to us and have us recognize you by the correct name, please go ahead and rename yourself. Stay muted when you are not speaking. And if you would like to talk and there seems to be a lot going on, but you want to make sure that you're recognized to speak, go ahead and raise your hand virtually using the reactions, and we'll recognize you to talk aloud. If you want to type a question instead of speaking aloud, you can always use the chat. And if you have any technical issues, you can chat privately to me, Jen Aloisi or AACE HQ. You can find me if you search both ways. With that, I am going to hand it over to McBib to go ahead and welcome us and tell us what we're going to do this evening.
Thank you. Thank you, Jen. I want to thank Jen and the American Association of Cancer Education for partnering with us to host this wonderful event this evening. I want also to remember, especially this month of March when we just had the Oscars, just a few days ago. A young man we lost in 2020, Chadwick Boseman, and a great talent that we lost too early. I'm very happy that, and we're blessed to have such a community in this area to create this regional collaborative on cancer disparities, a journey we started about a year ago, bringing together the health systems in the area, including Centera, Riverside, and Bon Secours, the institutions of higher education, including Eastern Virginia Medical School, Norfolk State University, and Hampton University, and community partners to think about the big challenge we have in the region. And by the way, I missed out to say, our wonderful colleagues, collaborators as well from VCU, Massey Cancer Center, are really representing a big region to think about the big challenge we have in cancer disparities, and thinking about ways of addressing it in more collaborative ways than we have had in the past. Coming together and thinking about prevention and screening. And addressing issues in more collaborative ways, so that we can really improve the outcomes that we have. Tonight we have this session which would focus on screening and prevention. And it's following what we had last week, also hosted by AACE on early onset colorectal cancer. And tonight's event is named the Blue Table Talk, a generational discussion on colorectal cancer with a focus on prevention, screening, and care. And I want to pass it on now and thank all the panelists first. They will be introduced by our facilitator tonight, Dr. Cynthia Romero, who will be introducing and facilitating the discussion tonight. So thank you all for being here, and we're very happy to have Dr. Romero. You're muted. Sorry.
Thank you. And thank you so much, McBib, and welcome everyone. It is a great pleasure for me to serve as your facilitator and moderator. I would like to start with some public service announcements related particularly to our continuing medical education, and want to clarify that this activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME, with the joint providership of Eastern Virginia Medical School, the M. Foskey Brock Institute for Community and Global Health, the American Cancer Society, Bon Secours Health System, Hampton University, Norfolk State University, Riverside Health System, Centera Healthcare, Shiloh Baptist Church, and Virginia Commonwealth University. Eastern Virginia Medical School is accredited by the ACCME to provide continuing medical education for physicians. And Eastern Virginia Medical School designates this live activity for a maximum of 1.5 hours of the PRA Category 1 credits, and physicians should only claim the credits commensurate with the extent of their participation. And we appreciate all of you for being part of our target audience. The objectives for tonight, and our panelists will be helping us to reach by getting information to you about examining our regional disparities in colorectal cancer and identifying community interventions to improve screening. We're also going to help identify community-based strategies for prevention and explain the challenges and best practices for delivery of care of colorectal cancer patients. All of our presenters and planning committee members disclose that they do not have any relevant financial relationships with ineligible companies. and a follow-up email will be sent to participants for attestation in order for them to claim the CME credits. So now we get to jump in to one of the reasons why we're here and why our Regional Cancer Disparities Collaborative have come together to seek your engagement and provide information. When we look at this information that was prepared by Dr. Relitza Maduro from Centera Healthcare, we see this is a summary of information about colon cancer mortality or death rates per 100,000. That's a way that they measure death rates. And it's actually an aggregate or accumulation from 2015 to 2019. And when we see that this is a reflection of colon cancer death rates, according to race, we have the white population and the Black population, and across the 7 cities within our Hampton Roads region. So Chesapeake, Hampton, Newport News, Norfolk, Portsmouth, Suffolk, and Virginia Beach. And if we focus first on the blue bars, which represent the white population on this slide, looking at the cancer death rates due to colon cancer, with the solid line first representing the state or Virginia rates of death, and then the dashed or dotted line representing the United States rate. Looking first at the blue, we see that there are several cities, in fact, all 7 have bars or rates that reflect death rates due to colon cancer higher than the Virginia state death rates. That means all 7 of our cities have higher death rates. Then when we look at the dotted lines, we definitely see that Chesapeake, Newport News, Norfolk, Portsmouth, and Suffolk, so 5 out of the 7 cities have higher rates of death in white individuals compared to across the state. Then when we look at the dotted line across here, we also see that Chesapeake, again, Newport News, Norfolk, Portsmouth, and Suffolk are higher. Now, when we look at the Black population depicted by the orange bars, again, with the dotted line representing the US rates and the solid line representing the state of Virginia rates, we see that Hampton, Newport News, Norfolk, Portsmouth, and Suffolk, 5 out of our 7 cities, have death rates in the Black community that are at or above both the state and the US rates. So we definitely have opportunity for us in our region to do something about it. And when we see these disparities, we definitely see opportunities for improvements. So now we are so incredibly grateful to have panelists to provide their perspective and to provide insights on how we could be doing better as a region, starting with our first panelist, Brandon Shackelford, who is a 33-year-old cancer survivor and alumnus of Norfolk State University, and he will be followed shortly by his mother, Stephanie Shackelford, who served as his caregiver and is currently a medical practice manager for Riverside Health System. So, Brandon, we now turn the floor to you.
Hey, good evening, everyone. My name is Brandon Shackelford, and I am an alumnus of the Norfolk State University. I hold the green and gold. I'm a 33-year-old cancer survivor. 2017, I was having some real bad stomach issues, and excuse the graphics, but I know when I went to the bathroom and I felt like I should be good, I was still having pain. And so I know my body. So I went to tell my mom, I'm like, hey, Mom, so I'm not feeling right. And so she said, well, maybe you should go to the doctor. I said, I don't know. But when she seen me drop to my knees, she said, no, you got to go to the doctor. And I was at work one time, and it was just excruciating pain. And so I had a friend go to the doctor with me because I'm not used to going to the doctors. So I talked to the doctor and let him know what was going on and tell him I was having pains. And I felt that I was just kind of being misdiagnosed, saying, oh, maybe it's Crohn's disease. I don't know, da da da. And he was saying, I really can't give you no colonoscopy until you like, unless you have blood in the stool. Or so me just thinking, I'm saying, well, I got blood in my stool. So he went on and got me the colonoscopy. And when they went to do the colonoscopy, from what I'm told, they couldn't continue the colonoscopy because it was something blocking the camera. So when I'm coming out of recovery, I'm still half dazed and I really can't hear nothing. I'm hearing the doctor talk to my mother, and he's saying, well, we did find a tumor, and that's what woke me up out of my sleep. Like, what do you mean tumor? When you hear tumor, you think the worst. And so got some tests done, came back, it was stage 2 cancer. I never would have thought that I would be 29 years old dealing with cancer. It's just something you really don't hear too much of. You have family members that may have passed through cancer, but when it gets to you and someone you know and love like yourself, it was just hard. And it really didn't hit me till probably like 2 weeks later, to after we did all the tests and everything, because my main focus was on who's going to take care of my family, which is kind of selfish. I needed to be thinking about myself and what I could do. But around that time, I was just thinking about like what my family going to do. And then one time I'll never forget, I was driving on 64 West, and like it just smacked me like a ton of bricks. Weeks later, saying like, yo, I have cancer. I have to see how I'm gonna deal with this. So come to the surgery, 20, I think they cut out 20% of my colon. Got a scar, of course, but I'm just thankful that I'm here to share my story with everyone.
Brandon, absolutely amazing story. Thank you so much for sharing your perspective. And we will definitely be hearing more from you during the question and answer sessions as well. But thank you so much for your incredible courage to share your story. And now we get to hear from Brandon's mom, Stephanie Shackelford, who, as many parents may have perspectives on, will share her feelings and just some insights that she has. So Stephanie, thank you so much for being with us.
Thank you for having me. You know, as a parent, of course, your job is to protect your children. When Brandon, like he spoke of, when, of course, he was saying he was having stomach issues. And as a parent, a lot of times you dismiss what your children are saying, you brush it off. Not until I actually saw the physical pain when he dropped to his knees was when I said, okay, it's something a little bit more. We did what we had to do. You know, you go into that flight mode to take care of your child. And Brandon is correct. When we got the diagnosis, or let me back up, when we went to have the colonoscopy, the caregiver that did the colonoscopy, to this day, it still touches my heart, because this provider actually came in. Brandon was on the gurney, and the provider actually, he was leaning on the wall and his face was just full with so much emotion. And he said, we could not finish the test. And I'm like, what you mean you couldn't finish the test? And he did say that, yes, the scope would not go past. And even after all of that, even if he said it was a mass, until Brandon had that surgery, after the surgery was over, I'm still hoping and praying that something was misdiagnosed or something. But even after that surgery, and they came out to talk to us, they actually pulled us a little room and they said, yes, it's colon cancer. We don't know the stage right now. And the whole idea that my son, you know, no matter what you do as a parent, you think you're doing everything right. And he actually ended up with colon cancer. And it was you just, all of a sudden, you just think, what could happen? Is he going to be here? What do we do next? And I am just so grateful for the health system. And we have to get this word out to everyone that do not dismiss what your children are saying to you. You know, actively listen, ask the right questions, follow up with them. It's so important because this cancer has no age. It has no age limit. As you can see, my son was 29 years old, you know, and all I can say, if as a parent, if you don't take anything else from this, actively listen to your children, as yourself, actively listen to your body. If you see something that's not what's the norm or what you think is the norm, speak up. Don't be ashamed to discuss it with your healthcare provider.
Excellent. Thank you so much, Stephanie. Again, you could feel her passion, and what a blessing it is for all of us to be here to hear directly from Brandon and his mom, Stephanie, and to be able to have them share their story so that they can help others save other lives. So that's why we're here. So again, Brandon and Stephanie, thank you so much for sharing your story. We'll get back with you definitely during the additional questions and answers. Now we're going to move on to our next panelist, who we are so grateful to have all the way from Los Angeles. Thank you, Zoom. Dr. Afolasaid May. She's an assistant professor of medicine at the David Geffen School of Medicine at UCLA. She's a member of the UCLA Johnson Comprehensive Care Center and a researcher at both the UCLA Center for Cancer Prevention Control Research and UCLA Kaiser Permanente Center for Health Equity. Dr. May, thank you so much for joining us today and sharing your insights.
Thank you so much for having me. And first of all, I just want to say thank you to Brandon and Stephanie for sharing that story and the bravery for sharing that story, because I think what Brandon said at the top really hit me. Just he almost wanted to apologize for stating what his symptoms were. And I think, quite unfortunately, that's what we see a lot with colorectal cancer, is that people are almost too embarrassed to talk about symptoms that involve their rectum or their anus, that involve changes in their stool or their bowels. And unfortunately, that stigma and talking about this disease has left us in a state that we're talking about it too late. And unfortunately, people are dying of it. And disproportionately, Black Americans, Black individuals are dying of it. But I just want to say thank you for having me. As mentioned, I'm zooming in from Los Angeles. I work at UCLA. I'm a health services researcher, and I'm also a quality director for our hospital, UCLA Health System. So I run a laboratory that really focuses on preventing cancer and detecting cancer early when it's curable. And the other hat that I wear for the health system is that I help design the quality improvement programs to make sure that all the patients that fall under the umbrella, that's UCLA Health, which is about 400,000 patients, making sure that all of them get screened for colorectal cancer. My goal today, I wanted to talk a little bit about some of the challenges that we see in healthcare delivery for colorectal cancer patients. And really, the challenges are on both sides. There's challenges in the screening and prevention, and there's also challenges in the treatment. So the patients who are diagnosed with colorectal cancer. And I typically like to break those challenges down into 4 levels. There's challenges at the patient level, at the provider level, at the healthcare system level, and with policy. And I think Brandon hit on a lot of the patient level challenges that we see. So a lot of times there's just not a high level of knowledge about this disease, particularly in younger adults. People just don't know that colorectal cancer is as common as it is. And we do studies where we do focus groups with patients, and particularly individuals of the Black community, and they're shocked to hear that colorectal cancer is the #2 cancer killer, and that Black Americans are 40% more likely to die from colorectal cancer than white Americans. So we have a long ways to go in just teaching people about their risk and making sure that people have the right health information, in addition to addressing the hesitancy about this disease that particularly impacts intimate parts of the body, as Brandon was alluding to. And, I think there's a tendency in healthcare to blame the patient and say all the problems are because the patient didn't know or the patient didn't act. And what I really try to push in our field is that the patient level challenges are just one level. There are many problems at the provider and the health system level, at the policy level as well. You know, the number one recommendation or the number one predictor that a person is screened on time for colorectal cancer is that their primary care provider told them to be screened. And unfortunately, we have primary care providers who, due to low amounts of time that they have with patients, overwhelming panel size, they don't get to talk about colorectal cancer with all their patients. And for reasons that we don't quite explain, I can't quite explain just yet, there is a little bit of a bias in that providers are less likely to recommend colorectal cancer to screening to Black patients. So there are many problems at the provider level that are predicting as to whether people get screened or get the attention they need for their symptoms, as Brandon touched on with his interaction with the doctor, you know, using those key words that get you that colonoscopy that you need. Because if Brandon hadn't said, I had blood in my stool, this tumor would have progressed. And that's unfortunate that a lot of patients won't have that insight. And then on the health system level, the system that you receive care in matters. So whether you receive care in a health system that has access to colonoscopy, access to specialty care providers, versus a healthcare system that doesn't have any of those things, are really going to predict your likelihood of getting appropriate care, of getting screening, in addition to policy level factors. So it was very beneficial for individuals of Black and Latino background in this country when we passed the Affordable Care Act. We know that people, especially low income and people from racial and ethnic minority groups, got better care and were more likely to get preventive services when the ACA or the Affordable Care Act, otherwise known as Obamacare, was passed. But it didn't close the gaps completely. There's still gaps in colonoscopy coverage in many states. And there are still, unfortunately, some health systems that you walk into and you can't get that diagnostic colonoscopy or the screening test that you need at the right age. So again, just highlighting that these problems and these barriers are occurring at every level, whether you're talking about patients, doctors, the healthcare system, or healthcare policy. And it's not really until we have advocacy at every single one of those levels that we are going to improve this problem and get rid of colorectal cancer. So thank you.
Thank you so much, Dr. May. And again, we'll have some questions on some of your recommendations later during the question and answer. So thank you so much. And now our next panelist is Dr. Bruce Waldholtz. And Dr. Waldholtz is currently the rector of the Board of Visitors at Eastern Virginia Medical School. He is a member of the National Board of the American Cancer Society Cancer Action Network. He is the past chair of the former South Atlantic Division Board and a longtime award-winning American Cancer Society and AACE Cancer Action Network volunteer. Dr. Waldholtz, I'm going to stop sharing my screen before your slides just so people could see your face and have you say some opening comments before I go to the slide. Oh, you're on mute, Dr. Waldholtz. You're on mute.
How about now?
That's it. You got it.
Okay. Well, thank you, Dr. Romero. Thank you, Brandon. Thank you, Stephanie. Thank you for Dr. May. It's a rare opportunity when a gastroenterologist is allowed to speak around dinner time because you never know what might be said. But basically, we're here to celebrate with Brandon, to celebrate the past, but we're really here to change the future with an eye for what we can do collectively. And that's what's most important. There's a line that's been out there that is, oftentimes there's more than said. When all is said and done, more is said than done. But we really need to make a difference here. And certainly at the American Cancer Society, we've been advocating on the national level for Medicaid expansion, which is insurance status certainly makes a huge difference. If we talk about, and that's a little American Cancer Society global, we'll get to that in a second. If you really want to make a difference, we really have to know, number one, to understand that colorectal cancer is very common. Number two, colorectal cancer is preventable with screening because it can be diagnosed at an earlier stage. And those of us in gastroenterology have spent, in my case, 37 years removing polyps so people don't get cancer. And I can tell you it's very disconcerting when the lights are down and the nurses are watching and you look inside the colon and you find this mass and you touch it with a forceps and you take a biopsy. You know that that person and their family's lives have been changed forever. And the first thought that goes through our mind is, how could this have been prevented? So rule number one is to know your family history. Rule number two is to know your risk factors. And certainly it is very important to know not just your genetic code, but your zip code, because the sad truth is, and there's certainly a lot of data within our health districts within Virginia and within each congressional district that the American Cancer Society has geospatial data on, that the risks are not uniform. In fact, the risks in Portsmouth, Virginia, of colorectal cancer are markedly higher than in Northern Virginia. And there's a lot of reasons for that we're going to talk about in the next minute or two. The things that we know work, we need to do better. Barbershops. It was shown in the early 1980s at Johns Hopkins. If you want to lower blood pressure in young African-American males, you check blood pressure in barbershops. Mr. Gamend and I and Michelle Cox from our ACS team have been talking for years about working with our barbershops. Our churches, we had a program with the historic First Baptist using fit testing over 2 years of making a difference. And I want to explain what a fit test is. A lot of people think the only thing that you can do is to get a colonoscopy. And the most important thing for the American Cancer Society guidelines, and now this is followed by the U.S. Preventive Public Task Force this year, is the right age, the right time, and the right test. So rule number one, or guideline number one, if you look at this slide, is 45 is the new 50. So if somebody comes in and says, I'm only 3 years overdue, I'm 53, no. The data has clearly shown that the risk, and particularly of lower intestinal cancer, and Brandon's cancer was not in the usual location where we see hereditary cancer. And one of the things I want to say right from the start, whether a patient has a cancer diagnosed by bleeding or by an abnormal stool test, there are two important things that have to be done. Number one, the patient has to be treated appropriately, and Brandon's life was saved with that. But number two, that's often forgotten, and often by the doctor not wanting to bring this up with the patient, but they have to think of the whole family. And when you have a patient really under the age of 60, genetic testing can be done to see if that patient has one of the 4 genetic mutations that are hereditary, and then other members in the family can be checked. And that's very, very important. We have to have access to that widely. We have to have access to biomarkers, which if somebody develops cancer, the standard of care today is not to just throw different chemotherapies, but to look to see what their genetic profile is. So screening age 45 to 75 has been shown to save lives. After 85, screening should be stopped because the risk is greater than the benefit. From 76 to 85, there should be individual discussions with the patient because we do not have data yet that it extends life. If we could have the next slide, that screening can involve stool-based tests. It can involve, actually the A, B, and C are for the age group. So just go back to the prior slide because that's what I'll end on. Really, the best test is the test that gets done. Colonoscopy every 10 years has been shown to decrease the risk of colorectal cancer. But not everybody can get a colonoscopy due to preference, fear, concerns, or insurance, or cost factors, or not being able to get a ride, which is actually an important thing. But FIT testing, fecal immune chemical testing, which is relatively inexpensive, anywhere depending on where it's done, may cost $10 to $60 frame. And within the federally qualified health centers, where over the last number of years we've increased screening rates nationally from maybe the 20s and 30s, trying to get to 80% as a threshold. That seems to be the glass ceiling for mammograms and colorectal cancer screening. But patients have the option of a FIT test or a Cologuard test, which is a combination of FIT and DNA every 3 years. Finally, does this work? Sure it does. We had 5 state roundtables in Virginia a number of years ago after meeting at the Kaiser Family Foundation. Other states had one. We thought because of different geographic parameters, it's important to have multiple ones. We had homeless men who were getting their care at federally qualified health centers bringing in stool tests because the MPH was from their area. So it's very important to have that trust. Finally, what I would suggest, if we're going to come up, there's 9 organizations represented on the initial slide. I'm involved with the first one, And the last one, maybe we could squeeze everything together here. We need a PR campaign. We need a plan. If you don't have a plan, it's not going to happen, to make sure that we're active within churches and barbershops to involve these students from Norfolk State, ODU, the MPH programs at EVMS. And I would go so far to bring up something that we brought up for years. We need to consider inpatient point testing. In the early 1980s at Johns Hopkins, we were required as interns to do pap smears on all women admitted to the hospital. The reason why is that cervical cancer was a big deal in inner city Baltimore then. There's a whole host of people that come into a hospital that may not have access to care, may not have a physician, and that may be the one chance there. So I just sort of wanted to bring that up. Thank you again. We'll look forward to our discussion. Thank you, Dr. Romero.
Yes, thank you so much, Dr. Waldholz. And now we'll move on to our next panelist, who is Dr. Michael Preston, who is an assistant professor in the Department of Health, Behavior, and Policy, and is a health services and systems researcher. He's also an inaugural Wright Faculty Scholar in Health Disparities of the Wright Center for Clinical and Translational Research at the Virginia Commonwealth University. Welcome, Dr. Preston.
Thank you, and I would definitely say it is an honor to be a part of this panel discussion, this engagement lounge today. And just thinking about, all the speakers and what they have discussed, some of the stories that was told, especially Brandon and Dr. May and Dr. Wardle. And I just want to, try to think about some of the different interventions that have not been mentioned that can be used to actually remove some of the barriers that patients, actually have when it comes to colorectal cancer screening. Because one of the things I've been able to experience as a health services researcher in the field for a number of years, a lot of the problems that we see, not only in Virginia, they apply across the board. Whether we're talking about lack of access, to the healthcare system, whether we're talking about lack of coverage for individuals that tend to be uninsured or underinsured, lack of knowledge, having the ability to navigate the healthcare system, low screening rates. One of the things Dr. May mentioned about African Americans tend to have a higher mortality or death rate compared to the rest of, the racial and ethnic groups. And when we think about that, we have to think about the role that screening plays. African Americans are less likely to be screened, and that, kind of contributes to why they're more likely to die from colorectal cancer. And in Virginia, in particular, Virginia is one of the three areas that has been considered a hotspot for colorectal cancer. If we look at the three regions, areas that has a higher mortality than the rest of the nation, Virginia has 26 of the counties that are considered hotspots. And, one of the things, we have to look at as well is, how do we get individuals to screening if, they have these different concerns, fear, embarrassment, as was mentioned. There's a lot of myths and stigmas tied to colorectal cancer screening. Time, cost, if you have to take off from work. And, the thing that has kind of stood out to me is talking with different individuals. My doctor never talked to me about it. So we have these missed opportunities to get people into screening because of a lot of these different factors. And so one of the things that we try to do is look at what evidence-based programs are out there. Right now, the National Cancer Institute has 22 evidence-based programs that have been proven to actually increase colorectal cancer screening within certain settings. I actually have one of those 22 evidence-based programs, and my program is actually designed for medically underserved population. So, if you have some time to get out there and, do some search on, some of these programs, then they're available for anybody that wish to use them. And another thing that I would like to talk about is we develop a patient navigation program. There are a lot of programs that use community health educators to do more group settings as far as education. There's also the community health workers. There's another opportunity to get people, educated and to look at, how do we remove some of those barriers to screening within certain communities. And usually the community health educator or the community health worker is someone that is from that community. They have, they're invested in that community. People trust them, and they're able to get people, the into screening easier than someone who may not be from that community. Another program that I would like to, kind of discuss, is the Screen to Save program, which is a national initiative, a program that is designed to actually develop culturally appropriate educational materials that can be used to increase awareness around colorectal cancer. And one of the other programs that I would mention is, we have a colorectal cancer health champion program that is designed to train, kind of a train-the-trainer program, where we actually work with community members who are interested in making an impact on colorectal cancer screening. And they have their, what we call fireside chats, and they go out and basically do the same thing. They just do it over and over, and then they train someone else who goes and bring in people that they can talk to them about colorectal cancer and the importance of screening. And so these are some programs that, I wanted to just kind of talk about. There are other programs. One of the things that I can say that you can do, this is Colorectal Cancer Awareness Month, is, join the Virginia Colorectal Cancer Roundtable if you're in the Virginia area, and, take the pledge to, get screened for colorectal cancer. You can also use your social media to get the word out, and during the month of March, we actually wear blue to show our support for colorectal cancer. We want to make sure that we increase the number of people that are wearing blue, kind of like, in October when everybody's wearing that pink. Everybody knows that when you're wearing the pink, what that means. You're supporting, breast cancer awareness. So we want to do the same thing for the month of March when it comes to colorectal cancer. And be an advocate for change. Policy is one of the things that we know that make, you get your most bang for your buck through policy. And so one of the things we're doing, we're working with a lot of our, partners, stakeholders, to try to look at, how can we get, some policy changes around colorectal cancer. And so if you're interested in doing some of that kind of work, feel free to reach out, and we will be sure to bring you aboard. Thank you.
Thank you. Thank you so much, Dr. Preston. And now before we jump into our final panelists, just remind everyone that if you have a question, you've heard our fantastic panelists, feel free to ask a question, type it into the chat box, and we'll get to it as soon as we finish with Iris Lundy. So our final panelist is Iris Lundy, who is a nurse, but she's also a cancer survivor and the Senior Director for Health Equity at Centera Healthcare. So welcome, Iris.
Thank you. It's so good to be here. I've enjoyed the conversation that has been going forth so far. And thank you, Brandon and Ms. Shackelford, for sharing your story, and everyone else who has provided their knowledge and expertise. When I was diagnosed with colon cancer, it was at the time when the criteria was at the age of 50, you would get a colonoscopy. Well, I was younger than that. So I'm so glad that we have dropped that age limit criteria. I think for me, one of the things that stand out is that I wasn't having stomach pains. I wasn't having problems with my stool. But, I remember being in a meeting and just becoming like very sick. It's like I was just dizzy, didn't know really what was going on. And this physician said, "Hey, I'm going to help you get better." And I was the current physician, primary care physician I have, I was telling him, I said, I don't know what it is, but it's something. And I just kept getting sicker, but it's like he wasn't hearing what I was saying. And I ended up, a friend of mine said, there's this doctor you should check out. And I transferred and went to see this other doctor. And this guy, he was like, you know what? I'm going to walk you through this. We're going to help you get better. I had already been in the hospital multiple times. No one knew what was going on. I've had these blood transfusions, and probably because I was less than 50, we didn't think about colon cancer. And I can tell you, I didn't think about cancer at all. And yes, I am a nurse, but let me be the first to tell you that when you hear that big C, you're not thinking as a nurse or anything like that. I was thinking that I am a mom and a wife, and I have to figure out how my husband and I were going to tell our family that I had cancer, and I didn't know what that meant for us at that particular time. And so it was really rough. And I tell you, it was my faith and my friends and my family that got me through that. And so, make sure you have advocacies, people who can walk this journey with you and talk with you. And I tell you, having a good physician is so important, one that hears you. This last physician I had, he heard me, and he was determined that we were not going to stop until we found out what was going on with me. And then when I got that diagnosis about cancer, it's like, wow, last thing you want to hear. But again, I had great physicians who walked me through that process. And I had my faith, family, and friends to walk with me also. I ended up having surgery, got part of my colon removed, and, just thankful for everything. But I can tell you, I wasn't thinking about cancer. And so probably some of you that are listening right now, maybe you weren't, or someone who hasn't thought about it. And I have this conversation often with my family, and I'm telling you, have the conversation with your family and friends. Brandon has showed us there is no age limit on this. This could happen to anyone. So when you're not feeling well, advocate for yourself or find someone who can help advocate on your behalf, but certainly go and get it checked out. Screenings is so important. Here's the problem, as we're coming out of COVID, while we were I don't even say coming out, let's just put it this way. When we were in the heat of the pandemic, a lot of us stopped going to the physician for many reasons. And because of that, we're behind on some of these screenings. And I am asking you, please go and get screened, right? There are many things you can do. I heard Dr. Walholz, I think he brought up the FIT test. We do a campaign with flu fit tests. While you're driving up to get your flu shot, we give you a fit test. We're working with our faith-based leaders so we can do that education out in the community too. And that's the other piece. We don't know what we don't know. So we have to get the word out so people will know what are the signs and symptoms. How do I advocate? Who can I turn to if no one is listening? What can I do? So I think there are many things that we can continue to do. And again, thank you for allowing me to share a part of my story. And I want to thank again Brandon and his mom for sharing theirs, and the others for sharing their expertise on this matter.
Awesome. Thank you so much, Iris, again, for sharing your story, which again is really giving us that call to action, right? Call to action to continue to advocate for yourself and others. I want to actually now continue to invite anyone who is listening and who have heard our excellent panelists to put in any questions you have or any particular thoughts that you want to share in the chat so that we could share those with our panelists. But I actually want to go back to Brandon real quick. So Brandon, since since you've gone through this experience and certainly hearing a lot of what the other panelists who are clinicians, who are researchers, who are trying to be advocates for improving this, how have you continued to keep yourself cancer-free?
One of the big things is changing my diet and working out more and trying not to stress as much, because I truly believe around that time, I was dealing with a lot of stress, fresh out of college, worrying about student loans, working and other things, making sure I'm doing what's right, thinking if I made the right decision in the career path I went. So just watching your stress levels and working out. I'm thankful to have friends that when I told them I had cancer, my friend Jamaris, he's a personal trainer. So he said, whatever we're going to do, we're going to help you. And my friend Demetrius, who's my trainer now, which this probably been the longest I've been working out since I played football. He's just encouraging me every day. And his fiance is encouraging me every day. And I have big support at home with my wife. She's encouraging me every day to, hey, go ahead, go work out. I know you don't want to, but I also think that 45 is still a little too old to be just trying to get the screening. We need to drop it lower to maybe the 29, 30s. 45 is like, if I would have waited till 45, I wouldn't have got that screening. So I think it needs to be dropped lower.
And Brandon, one thing that you had shared with us before the panel was that you are getting your screening and your follow-up colonoscopies. And what are you doing as far as preparing for those?
Actually, I think next week I'm going for my colonoscopy. Last year, I kind of skipped it just on financial reasons. So that's another issue we have to worry about as young adults coming out of college. You have to budget almost $600 to $700, and that's if you have good insurance with your job to make sure you could get that yearly screening, because I think I have to do yearly screenings until I don't know when, just to make sure. So the last screening I got, by the grace of God, they didn't find no polyps. So next week when I go in, I'll see if that year messed me up.
Thank you so much. So want to open it up now to some of the other panelists. When you're hearing Brandon and his strategies to try to keep himself cancer-free, are there other suggestions and resources that the system or physician offices can help provide to support the care of especially these young adults who are finding themselves in this situation?
I smiled listening to Brandon because I think there's so many things there that I wanted to pick up on and kind of emphasize. So we actually do know about dietary habits and a link to colorectal cancer. And I think it's important to know this. So we talk a lot about preventing colorectal cancer through screening, and yes, that's essential. But it's also important to know that there are things that we do to our own bodies that potentially put us at higher risk. And likewise, there are things we can change about how we live our lives to lower our risk. So as Brandon has touched on, diet matters. We know that diets that are high in fiber are better for our health, and that people who have a high fiber diet have less colorectal cancer. We know from studies that you should avoid processed meat, red meat in large amounts. We know that it's important that you get good amounts of vitamin D and calcium, that you avoid obesity, that you keep yourself physically active, that you avoid tobacco and heavy alcohol. These are all things that we can, with practice and motivation, control. So it is getting screened in time. It is paying attention to the symptoms, as Brandon has highlighted, but it's also making sure that we're doing the best that we can with the one body that we're given to live in. And Brandon, I know that there is a lot of discussion about that screening age, and they use very sophisticated models to try and determine at a population health level what the right age is for us all to start screening. But you're right, it's not going to capture everyone. It wouldn't have captured you. You couldn't have waited to 45. There's plenty of patients that I see when I'm doing colonoscopies that couldn't have waited till 45. So I think the messaging that we try to teach people, and as we continue to evaluate the screening age, is that you have to pay attention to the symptoms. So even if you're 23 or 33, you don't wait till 45 if you're having symptoms. The symptoms makes you ignore that age and you go ahead and get checked out. You get that colonoscopy, as Brandon does, as soon as you have one of those concerning symptoms.
Thank you so much, Dr. May.
That brings up a very good point, is if you look at cancer in general, there's factors that we cannot change. We can't change our age, our ethnicity, our genetic background. But the three factors that we can change are, number one, don't smoke. Smoking's actually gone up during COVID. Number two, don't drink alcohol. The World Health Organization now says the net overall safest dose, the correct dose of alcohol is 0. It used to be 2 for men, 1 for women. And finally, the American Cancer Society since 1947 has done population-based studies called Cancer Prevention Study. They've done Cancer Prevention Study 1. That was the study that actually showed conclusively that smoking caused lung cancer. Cancer Prevention Study 2, that was run from the early 1980s for about 25 years, showed the increased association of about 8 different cancers: esophageal, liver, stomach, breast, uterine, prostate, and colon being associated in populations of people with increased weight. So the American Cancer Society right now is re-looking at its prostate cancer guideline because of the increased risk in African American men. Since PSA testing has gone down, the rates of metastatic prostate cancer have actually gone up. But if you take populations of people, it won't necessarily, it may decrease somebody's individual risk if they've had breast cancer or colon cancer, but it is important not only to keep a healthy weight by diet, but there's data being looked at about total sitting time. Just like we know if you sit for 6 or 8 hours in a row, you could get a blood clot in your leg, you go on a long car trip. There's something going on with prolonged sitting for greater than an hour at a time, even in normal weight people who exercise. So one of the guidelines, so to speak, that may be coming out in the next 5 years or so may be to not sit for prolonged sitting in front of a computer for, say, more than 45 minutes without getting up. But weight certainly is very, very important.
Thank you, Dr. Waldholz. We had heard several times the importance of having the healthcare provider, the physician, hear what the patient's trying to express. We heard the challenges that Brandon had directly. We heard even how Iris had challenges. How would the panelists recommend for patients and their caregivers to continue to strategically advocate for themselves and those that they're caring for? What are some strategies that maybe health systems, physician offices are trying to do to change that system so it's not so hard for the patients to be heard?
Take the doctor away from the computer. Insist that your doctor, this came from Frida Bryant, who, am I still on there? Can you hear me?
Yes, Dr. Waldholz.
The late Frida Bryant, who was the first African-American air traffic controller in the U.S. Navy to rise to the rank of senior chief, died of metastatic breast cancer. And she taught many of us a lot of things. And one example she gave is when she had a new oncologist at Portsmouth Naval, and he just started typing on the computer. In that best air traffic controller voice that only Frida had, she said, "Lieutenant, put up your hands and rotate 180 degrees now." And said, "I'm over here. That's just the computer. The patient's over here. Now let's sit down and talk." And unfortunately, it's important that the patients have to train the doctors how to listen better.
Yeah.
And I think going in with a list of questions and having them written down is also important too. And the questions that Dr. Tom Smith from Johns Hopkins, was head of palliative care, but was a breast cancer oncologist, said is, number one, what do I have? And number two, what's going to happen to me? I'll leave a big space on the page.
Thanks, Dr. Waldholz. Dr. May?
Yeah, I agree. I think I'll just add that in particular, when we're talking about people who are from underserved medical backgrounds, marginalized communities, we have to recognize that there is a great deal of explicit and implicit bias in the healthcare system. And we need to empower members of our communities to be aware of that bias and to actively engage in fighting against that bias. So a patient can go into a health center well informed that there's something wrong with their body and walk out with very little being done if they don't feel empowered to speak up for themselves, to ask for second opinions, to ask for clarification when they don't feel that they're getting the care that they are due. So I do think that we've come to a time where we do have to recognize that there is injustice in our healthcare system. And you couple that with hesitancy from just the historical mistrust and mistreatment in certain communities, that there does need to be behavioral change, not only on the patient side and the provider side, but also just in recognizing that, it's going to take more than, I think, simple interventions to fix these problems. So I engage patients who are unhappy and I tell them, say that you want a second opinion, that you want a referral. If you're being told no, ask why, ask to speak to someone else. I think it's okay to do that. And I think, unfortunately, many people don't think it is.
Thank you, Dr. May. We actually have a question in the chat by Sheila. And she says, both Brandon and Iris mentioned having part of their colon removed. Please describe if it is something that is noticeable to them and what changes, if any, they may have had to make in their life. So we'll start first with Brandon. After you had your colon resection or your colon surgery, what were some of the changes that you've had to make in your life?
Man, actually, the year after I had colon cancer surgery, I had to go in for another surgery because I had a hernia that ended up poking out because they cut 20% out of my colon now. So it was easy for my hernia to go out. So it was easy for, it was just easy for it to come out. And so I had to, and actually that recovery was worse than the colon one. And so I had to kind of like take my time with everything, like even as far as working out. When I work out, I could only go but so far for so long, and I had to stop to let the hernia go back down. So once I had the surgery, after 5 years, I'm finally starting to feel normal, where I've been working out 6 months and haven't had no issue mesh or my hernia coming out. So that's one of the big issues, just working back too soon and just not taking, I wouldn't say I wasn't taking care of myself. I was more in a rush to try to get back to 100% and improve what I done messed up. And I took a step back and just, that was it.
And I'll just add for Sheila's question. I think that answer can be highly variable. It really depends on where in the colon or the rectum the cancer is and how much of the colon or rectum are involved. In some cases, we can take out a very small piece of colon and you'll have a 90% cure rate and you won't notice at all that any of your colon is removed. But unfortunately, particularly when the cancers are very low in the digestive tract, or if they're extensive along the digestive tract, we have to remove more bowel and we get closer to areas where we can have more complications. Some patients do need to have the ostomy bag, which is kind of an external rectum or storage place for their stool. I do think that there's so much fear about that sometimes people don't want to get care for colorectal cancer. So I try to emphasize for patients that, we don't want to wait so long that we have to do these extensive surgeries and that you're more likely to have complications. That's why we want to intervene early. And it's a minimal number of cases where there's severe complications like that.
Thanks, Dr. May. And Iris, did you want to share how the surgery has affected you?
Sure. My scar it wasn't a large scar. If that's what she's asking, at least in my opinion. And let me tell you, to be alive and have a scar, I'm happy to have that scar. I wear it with pride. I'm just excited. So that's one thing. I think the other piece that, we haven't really talked about is the mental weight that comes with a cancer diagnosis, even when you're cancer free. When it comes time to get that checkup, sometimes you're like, well, I don't know, and you're worried about it. You're wondering if it came back. But I would tell everyone, please don't not go get it. That didn't make sense, right? I didn't say that properly. Go get your screening. For a while, you're going to have to do it yearly. Do it. Let me tell you, do it like clockwork. Do not miss it. The other thing I had to change was my diet. That was something I had to make a conscious decision. And I didn't just do that for me. I did it for my kids because I needed them to see that I was willing to make a change so I could be around a while for them. And I wanted them to make a change so they could be around a while for me. The other piece that I'd like to comment on that Brandon had brought up was around the finance piece, right? That is huge. And we're doing some things, right? Like we're part of American Cancer Society. They're always giving out grants and all of this, partnering with community resources. There's some other cancer resources that are out there. The healthcare systems, I know we have like a cancer navigator that'll walk you through it. So here's my point. If you're uninsured or you don't think you have enough insurance, still go get checked out. Let us help you worry about how we will help you financially take care of this and how to help you get some of those other wraparound services. We have people who work in our hospitals or health systems that their job is to help you work that piece out. So let us take that off your mind, right? Let us walk you through that and help you with that.
Thank you so much, Iris. Dr. Preston had mentioned several strategies of leveraging patient navigation with community health workers and engaging messengers like Brandon to help spread the message related to prevention and screening. Dr. Preston, would you like to comment additionally on, other strategies that, say, Brandon and his other colleagues can help get messages out, particularly to the younger adults that may not see themselves at risk or who have the fear of getting screened?
Yeah, so I think being an advocate is definitely one strategy that can be used, more of the one-on-one conversations. Brandon mentioned talking with some of his, friends, family members who, maybe, discussing different symptoms they're having. So, that's always, one thing, a person that is in your immediate circle, peers, are great ways to get the message out. As I mentioned about social media, that's another way because I think, younger individuals definitely use social media. And a small media campaign is one of the things that we do, especially when we're trying to target certain populations. We use small media campaigns. One of the things that has been very helpful with targeting rural areas. We've worked with the rural communities, people that are from the community. We don't try to bring in outside people to actually do those small media campaigns. And so you could do the same thing with younger individuals as well.
Excellent. Thank you so much, Dr. Preston. We have Danny who has raised his hand. So Danny, please unmute and ask your question.
Hello. So I'm Danny, and I'm a senior at UC San Diego, and I'm part of the cancer outreach team under Dr. Seller. And I just have a comment and a question. So going up first, I'd like to say I'm really glad to have joined this meeting today because it was very eye-opening. So I know that cancer, like almost everyone or at every age, you could be at risk, right? But hearing about it is another thing. So I really like to thank Brandon and Iris for sharing their stories. And for the questions, so for the Cancer Outreach team, we're resuming going out to the grocery stores to actually spread awareness about cancer like breast cancer, liver, and colorectal cancer. And I guess the question I'd like to ask is that for colorectal cancer, a lot of people in the population or community might feel uncomfortable talking about it. So I guess how would you go about just spreading colorectal cancer information to people in the community?
So I'll start with your question, Danny. I think for me, especially if I'm talking to young people, I talk about people that they know and respect, right? If people don't know Chadwick Boseman, they know the Panther, right? The Black Panther. So however I choose to talk about him, but I say, look, here's somebody who's gone too soon. And we have to start thinking about ourselves and others. And so if I was at a grocery store, and I think that's a great place, so thank you for that. I'm going to have to add that to my repertoire. But I think that's how it started. Like some of these famous people who we know, love, and respect, right? When he died, it impacted us as a people, all people. And I think when we use him and highlight his story, I think it's one way that we can share in a very public place like that.
I'll just add to that I think Danny, I'll just say quickly, we just need to normalize the terminology. I don't have a problem using the words rectum and anus when I talk to patients and when I talk to individuals, whether we're in the community or in a barbershop. And I say these are uncomfortable words, but they're killing people. So we have to be comfortable saying your back end, or if you're even more comfortable saying your anus or where your stool comes out. We have to normalize those words, especially in our community, because people are dying every day of this disease that's highly preventable. Over 90% cure rate if we find it at stage 1, and 65% preventable by screening. So I think just need to get over our uncomfortability with those words and just start using them with normalcy, and we can change the culture around the disease.
Thank you so much, Dr. May, and Iris as well. We have a question actually from Joanne. She said, excellent speakers. Thank you for the amazing and informative presentations. Dr. Woltholz mentioned 4 genetic tests. And could you very briefly mention those, Dr. Woltholz?
Sure. It's actually one test done by one of the companies, such as Myriad Genetics, and the name of the gene test is PMS2, MSH1, MLH2, and MSH1, I believe. So those are the 4 known, and known is the key word, known genetic markers. And this is similar to years ago, we had the BRCA gene. And if you recall, people who clearly, if you probably know people who clearly had hereditary breast cancer, but the BRCA gene is negative. There's a new gene now called PAL, P-A-L, capital B2 for breast cancer. So it's very important if somebody who has colorectal cancer, certainly before the age of 50, everyone should have some sort of genetic test to quantify not only the risk for other people in the family, but their own risk, because there's a disorder called Lynch syndrome, and it's site-specific hereditary colon cancer. But if you have one of those 4 gene markers in a female, there's about a 40% chance of uterine cancer, and the guideline would be to have a hysterectomy after childbearing age. So that's, but anybody, it's called, you see a genetic counselor at often the oncology center. Centera has a genetic counselors also. They have master's degree in genetic counseling. They take an extended family history and they get the appropriate testing.
Thank you so much for that question. And thank you, Dr. Woltholz. I have a 2-part question for the panelists. We have learned in surveys that the respondents have had challenges with the FIT test regarding pickup and drop off. Are there ways of addressing that, number 1? And then the second question is, also, insurance seems to be another problem. How do we expand FIT tests, especially to underinsured individuals? So The first is related to the challenges related to FIT tests picking up and dropping off after they're completed. And then the second is how do we expand FIT test availability to underinsured individuals? I think Iris had touched on this briefly a little earlier.
I can tell you the state of Kentucky, they're now making FIT tests available at the pharmacy for people to go in and purchase, with the thought being, if we can get a test to see if we're pregnant, we can get a test to see if we have COVID, then that's what the state legislature in Kentucky passed. But there are different types of tests. Some of them require to put a material within the toilet bowl. Others, you set to check a color within the bowl. But it should, a lot of these, if they're done by LabCorp or one of the national labs, Polymedco, shouldn't be hard to, return, theoretically.
I think the one other thing I'll add about FIT screening. So we're very fortunate that when the United States Preventive Service Task Force recommended screening for individuals 45 to 75, they also outlined several ways that you could fulfill that recommendation. And there's actually 7 strategies. So FIT, which is the fecal immunochemical test, is the second most common colorectal cancer screening test. It comes in an envelope. It's a small vial. You deposit a stool sample in the toilet bowl and you use a scraper to collect a small sample of the stool, put it into the vial, put it into the envelope, and then you return it to the lab. And the lab is actually going to run that stool sample to look for microscopic or very tiny amounts of blood. It's a little bit different than a lot of tests in that the FIT screening is 2-step. So I actually get a little bit nervous when I hear about people getting them from pharmacies and from other places where they don't have connectedness to a healthcare system, because the whole point of the FIT test is to find people who have the blood in their stool, which then mandates the second part of the test, which is the colonoscopy. So yes, it's great that we're increasing access many different ways, but it's critical that those people who have the abnormal FIT result, meaning blood in their stool, see a doctor right away. And so it is, I think, a little bit more likely that will happen if the FIT kit is given through a health center. To answer that first part of the question, what we've done is we've actually started mailing these and mailing them with return envelopes so that people can mail them back to the health center. We've also provided a drop box in the health center where patients, if they're coming after work or before work, they can actually slip it into the hole without waiting in line or coming into the clinic or, passing their stool to someone at a front desk. We're trying to make it very convenient for people to either mail or drop these off in person.
Thank you.
What can you tell us what your current rate is on those cards? Because when people nationally have tried mail-in campaigns, they haven't been tremendously successful, certainly haven't achieved the 80% rate.
So Kaiser Permanente is the largest health system, and they actually use a mailed FIT program. And there's actually, they've had a lot of great success, which is wonderful. They're actually at 84% screened, and they attribute it to their mailed program. The other health system with a rate over 80% that's national is the VA, and they're starting to implement a mailed FIT as of next year. So it certainly isn't a one answer. With colorectal cancer, I don't think we're going to find one answer. I think we've proven that, and that we've rolled out screening tests since the 1980s, and we're nowhere near 80% screened. But I do think it's going to be a combination of different efforts that are going to appeal to different types of patients.
Just out of curiosity, do you know what the rates are at your center?
Yes, so I run our colorectal cancer screening program at UCLA Health. Our current screening rate is about 67%. We took a 5% drop during the COVID pandemic, but luckily we're able to recover most of that drop and primarily did that through mailed FIT and mailed Cologuard.
Thank you so much.
That's very good. That's a good rate. Good.
Yes, thank you so much, Dr. May and Dr. Waltholz. McBib, you have a question?
Yeah, I just wanted to follow up on this question, and we did a brief survey this month and asked a number of questions. What would be preferable, in terms of pick up and drop off, and some of the suggestions were having a mobile van in the neighborhood, to drop off and pick up, so that was like really the best choice that was given. And so we're considering all of these things as we're going through this campaign to see what would work. But the other issue is the question of the follow-up is a very important one, which has a financial context to it as well. How does that work when insurance is not involved?
Absolutely.
Yeah, Iris,
So,
did you want to say
speaking
something?
about the van, I think I was going to say, just to follow up to McBib, there is one, I think it's maybe South Carolina that has like the pooper scooper. So they do have a van that goes around, basically, picking up fit cards from different areas. And I think they've shown that they've had a pretty good return of those fit by going around to individuals or even the clinics that they've visited. So great idea.
I think it's a great idea.
And another suggestion, I think they're also doing some work trying to get people to actually submit their fit card. If they go to a provider who's part of their program, I think this is in South Carolina as well, they give them a card and say, hey, do you need to go to the restroom? You can do your fit test right here in the clinic before you actually go back and see the doctor. So they're giving people, they have a room designated just so people can go and handle their business while they're at the clinic and don't have to worry about taking that fit kit home.
Captive audience.
Yeah, Michael brings up a good point. We call that poop on demand. And I'm always impressed by the patients who are able to do that.
Exactly. Iris, you had something else to add?
Well, for those who are in this area, we have a health plan here, and probably many health plans do that, but Optima, they do mail out the fit tests also, and that has worked very well with us. Within our Centera Medical Group, they are also, they have a campaign that goes on around giving out these these fit kits in the office, but also when it is flu time, we're out there in the community. And so I invite those, when it's flu time, we will be out there giving out fit kits to those who meet criteria. So please come out. And then we have navigators that will work with you to get those from you, get them back, and so that you can get tested, get follow-up, that kind of thing. Just want to make sure we announce that. Thanks.
Great. Yes, thank you, Iris. Yeah, Brandon.
HBCUs, they have their homecoming events are real big. And so I feel as though maybe the Cancer Society should set up a tent, or Riverside EVMS set up a tent and pass out those fit kits during homecoming, because Norfolk State, probably the best homecoming, I will say that, the best homecoming. Not just the homecoming.
Yes. There you go.
We have tens and thousands of people to come back just for homecoming, and it's just like a big family reunion. And just to have that fit kit there.
Yep.
Yeah.
There you go.
I just wanted to add that we were at the MEAC. We had a booth at the MEAC, but we just did an educational program this year.
Yep. Yep. Awesome. And
Dr. Wayne Frederick is now on the National American Cancer Society board. I just had breakfast with him. So Brandon, I'm going to take that suggestion to him because that's awesome.
Yes, great suggestion, Brandon. And Sheila put in the chat that the Norfolk State University Center of Excellence in Health Disparities will be willing to work with the health system to make that happen. So there you go, Brandon. This is going to be an idea. We'll give credit to you. So
that's your typical homecoming. Yes.
There you go. That's right.
Sheila, give me a call. I'm happy to work with you.
And Centera, that's right. So everyone, in our final minutes, I want to give each of our panelists about 30 seconds to give a quick message, as parting thoughts for our audience. So I will start with Brandon. Final parting thoughts for our audience who joined us tonight to listen to you.
Be your own voice. Be your voice. If you don't like what you hear from your doctor, there's many other doctors out there. Man, just speak up for yourself. Watch what you eat and watch your stress. and it can happen to anyone. So just, man, I'm just really happy that I'm part of this panel right now.
Well, we've loved having you, Brandon. All the best to you. Keep smiling. Stephanie,
Yeah.
final thoughts for the audience.
Just lean on your family and just lean on your family. You know, they're there to support you. So that was my final thought.
Way to go, Mom. Thank you so much for being with us tonight. Dr. May, final thoughts for the audience.
There's a couple more days of March. It's Colorectal Cancer Awareness Month. Find 2 people who are 45 to 85 and ask them if they've been screened. If they haven't, tell them about getting screened.
Excellent. Thank you, Dr. May. Thank you for joining us from California. Dr. Waldholz, final thoughts for the audience.
Screening, education, and advocacy save lives. Let's save some lives together and change the future. And thank you, Brandon.
Absolutely. Thank you so much for your leadership, Dr. Waldholz. Dr. Preston.
Yes, I would like to let everybody know that the best test is the one that you can get people to do. So a lot of the work I've done is looking at how we empower communities for life. So if you ever look at, you know, the interventions that I mentioned, that's one of them, empowering communities for life. So go out there and get that screening done.
Absolutely. Thank you, Dr. Preston, for all your work. And Iris.
Yes, mine is around screening also. I'm saying make a commitment to get screened and make a commitment to take someone with you. But I'm asking you to do that tonight. If you call someone tonight and said, look, I need to make an appointment to get screened, call me tomorrow and hound me. Don't let me off the hook. Do that tonight so that tomorrow you don't make an excuse for yourself on why you can't do it.
Fantastic. Well said. Thank you so much, Iris. Just again, quick things from the chat. Dr. Gibson said Hampton University is going to support that cause, Brandon. So you've got a momentum going here for the homecoming at Norfolk State. And Jen, please, you all look and see the great resource that Jen has put in the chat regarding the triage cancer, especially for those related to the financial concerns. So final announcements. Again, thank you all so very much for joining us tonight. Special thanks especially to our panelists, to the planning team of our Regional Cancer Disparities Collaborative, and all of our colleagues, especially Jen and Dr. Preston from AACE. As participants, you'll be receiving an electronic post-event survey regarding tonight's session. Please help fill that out and help us better prepare for any future events. For those of you who would like to claim CME, you'll be receiving an email from our EVMS CME office to claim that credit and to attest for tonight's event. Thank you all so very much. Let's go save some lives together. Have a great evening and get screened. Thank you so much.
Thank you.
Thank you.
Thank you.